I'm back. Okay, let's wait for the slides to come up. You'll see my disclosures. They still haven't changed. And they're still not influencing my talk. Okay, CBT. So, learning objectives for this one. Understand the clinical guidelines for behavioral treatment of insomnia. Understand the two-process model of sleep, which we've already reviewed, and the 3 Ps, the predisposing, precipitating, and perpetuating approach to insomnia treatment, and understand the theory behind behavioral treatments and be able to implement some aspects of CBT-I, although you may not want to, but you'll know how. So clinical guidelines for treatment of chronic insomnia include goals of improving both the quality and the quantity of sleep, and improving the insomnia-related daytime impairments. So remember, daytime impairments are part of the diagnosis. We want those to get better as well, not just the sleep at night. Treatments should be targeted for each patient, considering the functional consequences of insomnia, the treatable underlying conditions, so that's all the comorbid things that go on, the medical and psychiatric history and comorbid conditions, and the risk-benefit ratio of various insomnia treatments. The guidelines continue to say that the psychological and behavioral interventions are effective and are recommended in the treatment of chronic insomnia. They're effective for adults of all ages. Studies have been done both in general adults and older adults. And these treatments should be utilized as an initial intervention when appropriate and conditions permit. And notice I have that bolded and italicized so that you don't forget that. CBT-I is recommended to be the initial treatment for insomnia, or behavioral treatments in general. The practice parameters from 2006 say that stimulus control therapy is effective and recommended. Relaxation training is effective and recommended. Sleep restriction is effective and recommended. CBT with or without relaxation is effective and recommended. Multi-component therapy is effective, and when we do CBT-I, we generally are doing multi-component. Paradoxical intention is effective and recommended. Biofeedback is effective and recommended. And probably the most important bullet point here is this last one. There's insufficient evidence for sleep hygiene education as a single therapy. And I'll repeat this again later. Sleep hygiene on its own is not an effective treatment for insomnia. We use it in combination with other behavioral treatments, but it's not a standalone treatment. 2008 guidelines suggested that initial approaches for the behavioral treatment of insomnia include either stimulus control therapy or relaxation therapy or CBT-I, which would include stimulus control and sleep restriction with or without relaxation. In reality, this is for reality, not necessarily the boards, but when we do CBT-I in the office, we generally do stimulus control and sleep restriction. Relaxation is rarely included. And actually what we often do is really the BT part, the behavioral treatment. We'll talk about the cognitive treatments, but many people don't ever do that part of it. 2005, so God, Barbara pointed out that the RLS Consensus Conference was more than a decade. I can't believe this has been a decade already since the State of the Science Conference that NIH had on insomnia. But they concluded that behavioral and cognitive behavioral therapies demonstrated efficacy in moderate to high quality randomized controlled trials. CBT is as effective as prescription medications for short-term treatment of chronic insomnia, and the beneficial effects of CBT, in contrast to those produced by medications, may last well beyond the termination of active treatment. In other words, the effect of CBT lasts for several years after you stop the treatment, and I'll show you some data on that. And CBT is currently delivered by mental health practitioners or physicians with formal sleep medicine training. Since then, of course, we now have online sites for treating insomnia with CBT and other approaches. So let's look at some data. Here is our data looking at the efficacy of non-pharmacological treatments. It's a meta-analysis of 59 different trials. So our, God, your colors are different than my colors. This orange, I always have trouble finding this arrow. The orange is the pre-treatment, and you've got purple up there is post-treatment. We have sleep onset, latency, and WASO, time awake after, I cannot get this arrow. Time awake after sleep onset, and what you see is control versus the behavioral treatments, and in both cases, those getting the behavioral treatments showed significant improvement in their sleep. I'm going to keep trying to find my arrow here. Here's another study comparing CBT to temazepam. The 4 conditions were CBT alone, temazepam alone, a combination of CBT and temazepam, or placebo. And you can see this study, all right, this is not, I want my arrow. Oh well. You can see that this study is going out for a 2-year follow-up, and the CBT condition showed improvement immediately upon post-treatment at 3-month, 1-year, and 2-year follow-up. CBT plus temazepam was effective up to the 3-month follow-up, but then lost effectiveness, and temazepam alone and placebo had very little effectiveness after post-treatment. So this is another study that shows that CBT on its own is actually one of the best treatments that we can have. So I'm going to now go into how we do CBT-I, and let's start with some general impressions, comments. You have to stay focused on treating the insomnia. I realize that very few of you are actually going to do this in your practice. I would hope you would try or have someone in your practice that would do it. But even if you're not going to do it, you need to know this. So you stay focused on treating the insomnia. Patients often have multiple problems, and this sort of gets them unstuck because they know what they need to think about. The improvements are easy to measure, and these improvements will help motivate the patient to keep going. And insomnia is not a serious life-threatening problem. It's really important to remind the patients about that. We keep the sessions educational, and we focus on sleep. So getting started. First of all, who should not get CBT-I? Severe untreated patients with PTSD, untreated bipolar disorder, people who are acutely ill, so you don't start it till after the acute illness is resolved, patients who are drug abusers or alcohol abusers, particularly those who are abusing stimulants or sedatives. And sometimes you can make modifications and do some behavioral treatments with some of these, but in general, these would be the patients that would not be appropriate for CBT-I. So who should get CBT-I? Well, patients with insomnia for more than 3 months, of course, and where that insomnia is impacting daytime function or causing worry. So essentially, anybody with an ICSD-3 diagnosis of insomnia would be appropriate for CBT-I. It's good for patients who are interested in something other than medication. Some patients come in and say, give me a drug, I don't want to do anything else. We try to explain, I try to get them to try CBT, but if they really don't want to do it, it's not going to work. Patients with comorbid conditions that may be exacerbated by poor sleep, which, as it turns out, is almost everything, but you have to weigh that if they have something where, if you're sleep restricting them to 5 hours, but sleeping only 5 hours is going to really exacerbate their pain or something else, you have to weigh which behavioral treatments you're going to use and how you're going to use them, or if you're going to use them. So, let's get started with it. What are the components? You always start with sleep education. You explain the 2-process model in lay terms and the 3 Ps. We often start with sleep restriction, where time spent awake in bed is reduced and we regularize their sleep schedule. Stimulus control, which works on reconditioning their association of the bed with sleep rather than with being anxious about not sleeping. Sleep hygiene. Cognitive therapy, which works on the maladaptive beliefs that the patients have, and as I mentioned, not everyone actually gets to the cognitive therapy. We really focus a lot on the behavioral part. And then relaxation therapy, which is optional. A typical treatment plan, and notice we give, it was almost there. There we go. We give a sleep diary always. They fill one out every week. So you start out by giving them the diary, teaching them how to use it. And then if you have that luxury, they fill it out for a week or two before you see them. In my clinic, I don't have that luxury, so in real life, I do a very complete history, and based on that history, I start my treatment, and then I give them the diary to begin that week. So the first session is education about sleep, and you might start both stimulus control and sleep restriction, or one or the other, depending on what the main problem is and how much you want to give the patients. And I'm going to go through each of these treatments in detail in just a minute. Session 2, you titrate time in bed, and you start some sleep hygiene. Most of cognitive behavioral therapy is about titrating time in bed. It almost always comes down to that. Session 3, you continue titrating, and you might add in relaxation training. Session 4, you continue titrating, and you add in cognitive therapy if it's needed. Session 5, you continue titrating, and then you start talking to them about relapse prevention and long-term habits. And then you could do a follow-up optionally 2 to 3 months later to see how they're doing and if they need anything else. The truth is, if they've done all this correctly, they've learned what to do. So anytime they start having insomnia again, which they will, they know how to sort of nip it in the bud, they know what to do about it, and they don't need to come see you again. So let's start with the education, laying the groundwork. As with any behavioral treatment, the patients have to buy into it. That's sort of what I was saying before. If they're not going to buy into it, if they just want a pill, some magic pill that's going to put them to sleep, this is not going to work. They have to be willing to make changes in their behavior. I always educate them about the fact that these changes are temporary. If I tell them they can only be in bed for 5 hours and they go, "What?" I go, "This is just for week 1. We're doing it a little bit at a time, and we're slowly going to get you back to your 7 to 8 hours, or to that, because they're not actually there." So it's education and sort of a lot of hand-holding. You tell them that some of the recommendations you're going to give them are counterintuitive. They're being asked to do the opposite of what they've been doing so far. And what they've been doing so far not only hasn't been working, it's been perpetuating the problem. So it's important to change those behaviors. The education lays the groundwork for relapse prevention. That's what I was saying before. They learn what to do so that they can then do it whenever they need it. And this part, this educational laying the groundwork part, is really more sales than psychology. This is where you're really talking them into or convincing them or explaining to them why it's important to make behavioral changes. So we explain the 2-process model. We go through the 3 Ps, because what the CBT-I does is it focuses on those perpetuating factors. Our initial focus is on sleep quality, and sleep efficiency is sort of the cornerstone of all CBT. So I've already walked you through this. I'm not going to do it again, but what I say to the patient is, I don't use all those fancy words I used with you. I just say that sleep is like a homeostat for your temperature at home. It's a homeostatic balance. You have to be awake a certain amount of time before you're sleepy enough to fall asleep, and you have to sleep a certain amount of time before you're awake and make it through the day. And our biological clock plays into that, and we have to keep these two in sync. And that's about all I say, so they understand that homeostat. Spielman's model of insomnia. I should make us all take a moment of silence. Art Spielman died a few weeks ago, and we're all very sad. Spielman's model of insomnia, the 3 Ps, are this predisposing, precipitating, and perpetuating factors. And what this says is, everybody's got some sort of, or many people have some sort of some combination of these predisposing factors for insomnia. It could be an anxious personality, a depressive personality. Not that they're depressed, but just a depressive personality. They might tend to worry about sleep. They get anxious about it. And they have that decreased homeostatic sleep drive. They're a little hyperactive, and they have a decreased sleep drive. But that's not going to cause or start insomnia. That just predisposes them to insomnia. What precipitates the insomnia are the precipitating factors. The medical or psychiatric illness, suddenly getting sick. The medications that we give them for these illnesses. Shift work, or some stressful life event that precipitates the insomnia. But even then, it would be acute. It's the perpetuating factors that turns that acute insomnia into chronic insomnia. And these perpetuating factors are all the things that they try to do to sleep better, which are actually counterproductive and make the insomnia worse. And what we do with CBT is we try to break it right here. We try to get those perpetuating factors and turn them around to make them more conducive to sleep rather than counterproductive. And we explain that to the patient as well. So here's another model, and what this shows you is it's the same model but a different way of looking at it. So the premorbid, the predisposing factors are down here, and it's only when you get the precipitating factor that it might become acute. But at this point, since it's only acute and may only last a short time, if they need treatment at all, and often they don't, if they do, you might do a very short course of some FDA-approved sleeping pill, pharmacotherapy. But it's when the perpetuating factors come into play here that it goes into chronic, and that's when we start doing CBT. Okay, let's talk about the specific treatments now, starting with sleep restriction. Sleep restriction is particularly effective for those people that are spending too much time in bed. The more time we spend in bed, the more fragmented and disturbed sleep becomes. The less time you spend in bed, the more consolidated sleep is. What does an insomniac patient do? God, I didn't sleep a wink last night. I'm going to go to bed an hour earlier to try to get more sleep. Now they're actually extending time in bed, which is making their sleep even worse. So with sleep restriction, they're spending too much time in bed. We're going to limit that. It improves sleep continuity by limiting that time in bed to match the reported time of sleep. So you ask the patient, how many hours do you estimate you sleep a night? And I emphasize the word estimate because we have no idea where reality lies. And this is a very important point about CBT-I in general. We haven't done a PSG. Most likely we haven't done actigraphy. We're basing everything on the patient's report. It's not treating reality, it's treating the patient's perception. But it turns out that perception is really important because when you fix that perception, their sleep improves. So we're limiting time in bed to match the reported sleep time, which increases our homeostat. What we're essentially doing is sleep depriving them to try to increase that sleep need, and by increasing that sleep need, they're able to fall asleep faster and stay asleep faster. And I actually explain that to them. I use my hands a lot and show them what all that looks like. Total sleep time is determined from the sleep diaries. In my cases, I say I do it based on that initial history. I just ask them, how long do you estimate you sleep? And we start from that. And sleep restriction is useful both for sleep onset problems and sleep maintenance because of that sleep drive, helping to both fall asleep and carry them through the night. So, time in bed, and it's all about sleep efficiency. So, normal sleep efficiency, 90 to 95%. Average sleep efficiency in most sleep clinics is about 70%. No one ever sleeps 100% of the time, so our goal is they hit a sleep efficiency of 85% or higher. We calculate the sleep efficiency from their sleep diary, which they're completing every morning when they wake up. I try to emphasize to them, not in the middle of the night, not before you go to bed, not when you're sitting in the waiting room. Actually, we give them an electronic one, so they almost have to do it as they go along, but they're filling it out every morning. And then we look at that sleep efficiency to decide what we're going to do with them. So we look at the total sleep time that they report, and we establish a fixed wake-up time. We negotiate that with the patient because it has to be the same day, same time, 7 days a week. So I say, realistically, what time are you going to get up every day? Is it going to be 6? Is it going to be 7? We negotiate that out. And then, using their estimated total sleep time, we work backwards to determine what time they're allowed to go to bed. So if they're asleep, if they estimate 5 hours of sleep and their agreed upon wake time is 6, they are not allowed to go to bed until 1 o'clock. Most of them will gasp at this point. And again, you explain that's only for the first week, and remember, you told me you're only sleeping 5 hours anyway. This gives you 5 hours, and you sort of have to walk them through that initial shock of what you've told them to do. They're not allowed any napping, so no sleep outside of this window that we've agreed upon, and then we look at the sleep efficiency, and each week we adjust their time in bed. So if the first week they come back, we look at their sleep log. If sleep efficiency is less than 85%, we decrease their time in bed by 15 minutes, so now it's 1:15 before they're allowed to go to bed. If it's greater than 90%, we increase it, so now it's 12:45 that they get to go to bed. And if it's sleep efficiency is around the same, we just leave it, the time in bed, the same. If it's not, it doesn't fall into those other two categories. So that's sleep restriction therapy, and we do that every week. And every week, hopefully they'll hit 85%, or when they do, we slowly increase that time in bed, always getting up at their agreed-upon wake time until we have them sleeping at whatever their goal is. For me, their goal is always 7 to 8 hours, but you have to discuss with them what their goal is. Stimulus control is considered one of the most effective behavioral treatments. This was started by Dick Bootson, who also recently died. We're losing all our behavioral therapist grandfathers of this field. It's used both for sleep onset and sleep maintenance, and it's really based on classical conditioning. What happens is that the insomnia leads to stress, anxiety, wakefulness. Because this takes place in bed, they start associating the bed with being anxious and not being able to sleep. I don't know, can you, yeah, you can see that. It's not showing up well here. And what stimulus control does is it breaks that association. So instead of associating the bed with being awake, they learn to associate the bed with being asleep. So what the rules say is if you're not asleep, you get out of bed. Over one or more nights, your sleep drive increases, right? That's our homeostat. And sleep onset will begin occurring more quickly. And over multiple trials, as you fall asleep quickly in the beginning of the night or when you go, or in the middle of the night, you start associating the bed with sleep rather than with stress. So here are the actual rules. Again, a fixed morning rise time, 7 days a week, regardless of how much or how little they slept the night before. The bed is only used for sleep. And sex, and I always add, and sex only if it's satisfying. If it's frustrating, I don't want you doing that in the bedroom either. Bed is only for things conducive. I often recommend the kitchen table to them. The bed is only for things conducive to sleep. You're only allowed to sleep in your own bed, not in the guest room, not on a couch, not in a chair. Because again, you're learning to associate sleep with your bed. So wherever it is that you want to be sleeping, that's where you have to do this. You only go to bed when you're sleepy. So this, I think I was saying earlier, right? Some patients will say, I go to bed at 10 o'clock because that's when my husband goes to bed. No, if you're not sleepy, you don't go to bed. Only when you start getting sleepy do you get into bed. And if you're awake for more than about 20 minutes, you get out of bed. Now, why do I say about 20 minutes? Call it out, somebody. There's no clock, right. So when we get to the sleep hygiene, one of the first things we tell them is get rid of your timepieces. No timepieces in the room. If you need an alarm, you stick it under the bed or in a drawer. So it's about 20 minutes, and what I say to them is what that really means. I mean, the rule actually says about 20 minutes. What I really mean is the second you start getting tense or anxious or tossing and turning because you haven't fallen asleep, you get out of bed. You are never in bed if you're not relaxed. So you leave the bedroom. I already said that. No clock watching, I said that. Oh, this is just showing you what happens. By the way, and I explained to them why I don't want them to look at the clock. Not only does it put a lot of stress on you, oh my God, it's 2 a.m., oh my God, it's 2:01, oh my God, it's 2:07. But when you wake up in the middle of the night and you look at the clock, what you've done is you've taken yourself from N1, I say to them, transitional sleep to full awakening. Now it's harder to fall back to sleep because of our homeostat. You haven't been awake long enough to be sleepy enough to fall back to sleep. So they need to understand, I think any rule you give them, they have to understand why you're giving them that rule. Okay, so we got up to no clock watching. So they only go back to bed. Here's my arrow. They only go back to bed when they're sleepy. So they've gotten out of bed, they go into another room, they do something relaxing. The point they feel sleepy, they go back to bed. If, lo and behold, when they get back into bed in about 20 minutes, they haven't fallen asleep, they do it all over again. And they keep doing that until they can get into bed and fall asleep. Along with that, they still have to get up at the same time every day. So I literally say to them, you may not fall asleep till 5 o'clock. If 6 o'clock is our agreed upon wake-up time, you get up at 6 and you're out of bed. No napping that day. The next day, sleep drive will be higher. You'll have an easier time. If not, you do the whole thing again. And the idea here is if you're only using the bedroom for sleep and or sex, or not and or, but sleep, maybe sex, the odds are only 1 in 2. There's a better chance that you'll start associating this bedroom with sleep. If you're eating in bed, reading in bed, watching TV, etc., it's 1 in 8. There are a lot of things you're going to associate with the bed other than sleep. So, it's good to review with them what they should do when they get out of bed while you're doing stimulus control. We tell them, assume you might be up all night. So think about what things make you relaxed and calm. And by the way, and if you tell them you might be up all night, that gets rid of their anxiety. It's unlikely that that's going to happen. So if they do fall asleep, they feel great. You want something that's quiet, that's not going to wake them up or activate them. So you don't want them cooking for the next day or cleaning the house kind of thing. Not something where they lose track of time, but the most important part is it has to be something that they can stop immediately as soon as they start getting sleepy. So I tell them, if you're going to read, you don't read a book that's going to suck you in where you're going to, even though you're sleepy, you're going to keep reading because you want to get to the end of the chapter. Or if you're watching TV, you're not watching a movie where you're going to force yourself to stay awake so you can see the end of the movie. I tell them, watch infomercials, read a magazine, something that's easy to turn off or put down. If they meditate, that's a great thing to do at night. But the key is to work with them to find something that they find relaxing. They don't get on the computer and do emails. They don't get to, pay bills, to do anything that's more arousing than you want. You want them to try to stay not in a dark environment. It's hard to sit up and do things in the dark, but as little light as is possible, because of course light inhibits melatonin secretion, makes it harder to sleep at night, and we don't want that. They only go back to bed when they can't stay up any longer, and you only sleep in bed. Okay. So we send the patient home with a sleep diary. We explain to them that it's more art than science, that it is not reality that we care about, it's what it feels like to them. And as I said, they complete the diary in the morning. Okay, sleep hygiene. So we do include sleep hygiene when we do CBT-I, it's just so we're not doing it on its own. And this is education about their behaviors, about the environment, and other factors that might interfere with sleep. We rule out specific behavioral or environmental causes of poor sleep. So my pet peeve is patients who sleep with their pets. The two hardest things to get patients to change, one is throwing the pet out of the bedroom. They'll throw their kids out, but they won't throw their pets out, and alcohol. So sometimes you just have to work around the pets, but you want to sort of talk about what's going on at night in the bedroom that might be interfering. Is there a neighbor who goes to work at 3 in the morning and the garage door is waking them up? Is there light coming into the bedroom? Those kinds of things. And then you identify those issues that you want to target, because you can't make all the changes at once. You want to pick out 1 or 2 at a time. What sleep hygiene is not, it is not a handout. You don't take a printout that you got from somebody and just hand it to them. It is not evidence-based care. There's no evidence to suggest it works on its own, and it is not an effective standalone treatment, as we said. All right, one of my favorite cartoons. This is Mrs. Bear. I'm pretty sure this is Mrs. Bear lying down and Mr. Bear sitting up, and she says to him, "How many times have I told you no coffee after September?" So, no coffee after lunch. That's what we tell our patients. Many of them are having several pots of coffee all day long. It's amazing to me that they haven't put that together with the fact that they can't sleep. They'll tell you that the caffeine has no effect on their sleep. We get them to stop anyway. All right, sleep hygiene rules. Reduce time in bed. That's the sleep restriction part. Keep a regular sleep schedule, especially a regular wake-up time. You actually can't control what time you fall asleep, and you're not going to bed unless you're sleepy. So it's that wake-up time that has to be very stable, and that also helps stabilize the circadian rhythms. Eliminate the clock, we talked about that. Exercise, always a good idea. Exercise, the more physically fit they are, the better they'll sleep. Depending on the timing, it might help deepen sleep, it might shorten sleep onset, they might fall asleep faster, but you don't want them exercising too close to bedtime, because then it becomes alerting, so you have to get the timing of that. Avoiding caffeine, nicotine, alcohol, you know all the reasons why they shouldn't do that. Eating a light bedtime snack, it helps avoid awakenings due to drops in blood sugar at night, so you don't want people going to bed hungry. the other hand, there are data now related to obesity that is suggesting that all eating should happen in a 12-hour window. You should essentially fast for 12 hours, so that may limit if they can have a bedtime snack or not. Quiet, dark room. Clearly, that's very important. Blackout curtains if they're having problems. Light is the biggest enemy of sleep. Got to have a dark environment. Comfortable temperature, good mattress. People say, oh, so what mattress do you recommend? I recommend any mattress that you find comfortable. It's really an individual thing. And the same thing with comfortable temperature, which is a problem when you have a husband and wife and what each one considers comfortable temperature is totally different. So it's another whole story. Avoid trying to sleep. That's what an insomniac does. Oh, I have to fall asleep. Oh, I gotta. When they try really hard to fall asleep, and the harder they try to fall asleep, the more tense they get, and the harder it is to fall asleep. So don't try so hard. And again, if you start getting tense and anxious, you get out of bed. And no napping, because the napping decreases that sleep drive. Napping in general is a very good thing. It helps consolidate memory, has all sorts of beneficial effects, but not if you have insomnia. So an insomniac can never nap, because the whole goal of treatment is to increase the sleep drive, and a nap just dissipates that whole thing. A worry time. This always gives our patients a chuckle, but it is very effective. So in our busy schedules, the first time we often have to sit down and think is when we get into bed at night. And that's the wrong time to start thinking. So we tell our patients to find 10 minutes during the day where they can turn off their phones and put out a do not disturb sign and sit and worry. That's a time, especially the people that are doing this, at night, and they're telling you it's their thoughts that are keeping them awake. That's the time for them to sit and think about all the things they think about at night. If they want to make a list, they can make a list, whatever works for them. But really focus on all those things that are bothering them. At the same time every day, again, it's all part of classical conditioning. What this does is it frees them from doing it at night, and if they start doing it at night, they can say, wait, I have from 10 to 10:15 to do this tomorrow. The key is not to do it close to bedtime, so morning, early afternoon, no later than that. It sounds silly. It is very effective for many patients. Okay, teaching sleep hygiene. In rare cases, a clear sleep hygiene issue might arise, like, oh God, I'll die before I give up my coffee. It's all I drink. Well, they're going to have lots of bad habits, and you just have to educate them about the fact that they won't actually die. If they're really drinking that much coffee, you might want to wean them so they don't start getting headaches, etc. But as we said, correcting all these problems on its own is not going to be sufficient. So if you are going to do sleep hygiene, you identify 1 to 2 issues, the worst ones. Ask the patient to maintain that change for a couple weeks. They add it onto their diary, any changes that they've made, and then as you're following them up with a CBT, you follow up on that as well. Once they're fixed the first 2, you might start working on the next one, or depending on how many poor sleep hygiene things they're doing. There is another type of behavioral therapy that Dan Bicey and his colleagues in Pittsburgh developed that now has quite a bit of evidence base around it, called Brief Behavioral Treatment of Insomnia, or BBTI. And it's essentially a combination of sleep restriction and stimulus control that's done in 4 steps and can be done usually, in his studies that he's published, it's done in about 2 weeks. Rule number 1, reduce time in bed. Rule number 2, don't go to bed until you're sleepy. Rule number 3, if you're not asleep, get out of bed. And 4, get up at the same time every day. So it's taking the 4 most important points from each of the other therapies and just integrating it into one. So that's something that could be a question you might want to know about. There are also quite a few internet-assisted CBT-I programs now. I have some of them listed up here. The data suggests that these can be very effective, especially if there isn't a therapist around that can help the patient, but the patient has to be extremely self-motivated. Otherwise, it's not going to work. Many of my patients, I find, really need that hand-holding. They need the weekly contact. I can't see them every week. I do it via the portal, our electric medical records portal. They send a log back. I look it over and I send them a message telling them on what changes they need to make, but at least it's weekly contact. With the internet assisted, they're really talking just to the computer, and so they have to be extremely well motivated. But if they are, this can be an effective way to use CBT. Okay, that's the BT part of it, the behavioral therapy. What about the cognitive therapy? So this challenges the maladaptive behavior, maladaptive thoughts, or the dysfunctional beliefs that the patients have about sleep. For example, I have to sleep exactly 8 hours. I mean, that's what all the literature, that's what you've been telling us. I have to sleep exactly 8 hours. If I don't sleep 8 hours, I'm going to blah, blah, blah. Well, yeah, we'd like you to sleep 7 to 8 hours, but if you sleep 6 hours and 45 minutes or 6.5 hours, you're not going to die, right? So you got to deal with these beliefs. Correct unrealistic expectations. I should never wake up at night. Well, everybody wakes up at night, right? The key is how difficult is it to fall back to sleep. So you deal with that. And reconsider the consequences. If I don't sleep exactly 8 hours, I can't function. Well, you haven't been sleeping 8 hours, and what's the worst thing that's happened? Have you lost your job? Has your husband left you? You know, you actually go through, you have them tell you, what's the very worst thing that can happen? Well, has this happened yet? Well, no, it hasn't. Okay. So you, in that way, you deal with all these dysfunctional beliefs. As I mentioned several times, a lot of people that do CBT, although we call it CBT, really just do the behavioral part. It's only if the cognitive part comes out as being really an obvious problem, then you start dealing with that. So one of the actual words you might use with a patient is when you start the cognitive therapy. So far, we have focused on what people do that can make insomnia worse, like spending too much time in bed or napping. Now we're going to talk about another piece of the puzzle. That is what we think also impacts our sleep. And then you go through their thoughts, their worries, their concerns, etc. We'll also talk about how the way you think about sleep can be helpful or not helpful. And notice I did not say right or wrong. So you want them to know that there's nothing, it's not a question of being right or wrong, it's a question about what's going to be helpful and what isn't. Words when you're doing cognitive therapy are very important. Okay, prevention, relapse prevention. First of all, you have to remind them that one bad night's sleep is not a relapse. One bad night's sleep is not even insomnia. So once, everybody's going to have a bad night now and then, don't panic. If the insomnia really comes back, it might be a sign of other psychological distress, so you may either want to explore that or send them to someone to explore that. It may be a prodromal symptom, for example, depression, alcohol abuse, etc. And if it does return, restrict and control, sleep restriction and stimulus control all over again. They've learned how to do it. My patients often, if I follow them up in a year, or they may just let me know, I started having some bad nights again. I knew what to do. I did it, and it got better. It's, you've heard the expression, you can give a man a fish or you can teach him how to fish. And I say this to my patients. I say that to them. I say, well, what I'm doing is rather than giving you something to make your sleep better, I'm teaching you how to sleep. And once you've relearned how to sleep, that's going to stay with you forever. A night of insomnia isn't the end of the world. So these are some of the guidelines again. Psychological and behavioral interventions are effective and recommended in the treatment of insomnia. These treatments are effective for adults of all ages, including older adults and chronic hypnotic users. I didn't mention that if someone is taking sedative hypnotics, the best is if you can wean them off, but if you can't or they don't want to, it's okay to leave them on it and start the CBT anyway. You can do both at the same time, and eventually as they learn to sleep better, they'll be more willing to go off their sleeping medications. Let's see. These treatments should be utilized as an initial intervention when appropriate and when conditions permit. Initial approaches to treatment should include at least one behavioral intervention, stimulus control, relaxation, or the combination of all of it. Although patients with chronic insomnia should adhere to rules of good sleep hygiene, insufficient evidence to indicate that sleep hygiene alone is effective. Should always be used in combination. Okay, that's the lecture part. I'm going to give you, I think I've got 3 questions now for you to answer. So the first is, the 3 Ps of insomnia in order are predisposing, precipitating, and perpetuating, and CBT targets the precipitating. I'm going to get tongue-tied here. Predisposing, precipitating, and perpetuating, and CBT-I targets the perpetuating. Predisposing, perpetuating, precipitating, and CBT-I targets the predisposing, or predisposing, perpetuating, precipitating, and it targets the perpetuating. And I expect you to all get this right. Very good. 77% of you got it right. I actually had to read through it and remember which order I had them in here. That's correct. So a few of you didn't quite get it, but you will now. So it's predisposing. That's what most likely is your personality that might predispose you. Precipitating, that's that one factor that starts the insomnia. The perpetuating is what makes it chronic, and we target those perpetuating factors. Okay, next one. Components of the behavioral part of CBT-I always include which of the following? Sleep restriction, relaxation, and sleep hygiene. Stimulus control, relaxation, and sleep hygiene. Sleep restriction, stimulus control, and sleep hygiene. Or stimulus control, relaxation, and sleep hygiene. Go. You probably don't need a full 10 seconds here. Oh, maybe you do. Got zeros. Whoops. All right, I don't know what I did. Do we have the answers? Well, I screwed it up, but I'm sure you all got it right. The answer is sleep restriction, stimulus control, and then we add in the sleep hygiene. Relaxation is optional, so you don't always do that. Okay, I think this is the last question. Which of the following statements supports the clinical guidelines for behavioral treatment of chronic insomnia? I'm exhausted after 3 talks. I'm going to let you read it yourself. Okay, behavioral treatments should be utilized as initial intervention is the correct answer. I think I said that a lot of times. So third of you picked 3 initial approaches to treatment should include at least 2 behavioral. So that's also true, but the guidelines actually don't list it that way. So A is still the correct answer. And then just to summarize, our bottom line, sleep is controlled by both our sleep drive, our homeostat, and the circadian rhythms. 3P model suggests that predisposing, precipitating, perpetual factors determine insomnia, and CBT targets the perpetuating factors. CBT should be the first line of treatment. Stimulus control and sleep restriction, that should not say restrictive, it should say restriction therapy, are effective without any cognitive component, and sleep hygiene is not an effective standalone treatment. And that's it. Thank you. And I'll see you all tomorrow morning again.